I'm so excited to welcome you all to Happy Go Lucky at Heart podcast. I have a mission to support others with undiagnosed autism to get a diagnosis because my mum fought a long battle. But please don't go, because this podcast is for absolutely everybody, especially mental health too. And I mean everybody, because I will share with you lots of unique yet personal stories from all age groups. So please meet your host, Vicky Kidson, otherwise known as me. Buckle up, because it's going to be a long mission. So enjoy and live life to the full. In this episode, we have Dr. Loucresie talk about anti-racism, neurodiversity, and mental health. I hope you enjoy this episode. Give us some love. So I'm going to talk about anti-racism and mental health and autism, neurodiversity. How do you ensure that your practice is culturally responsive when working with patients from marginalized communities?
So I think one thing that I do is I'm a Black woman, but even as a Black woman, there are different cultural norms in Black people also, but also I see a lot of Indigenous people and other people of color that are not Black. So I think one thing that I do really is listen. If I don't know something, I follow. So online, so outside of my patients, not putting the burden on my patients, I follow, Indigenous people, Asian activists, other minority, where it's disability rights, deaf rights, whatever the case may be. I try to make sure that I keep my ear to the ground or listening to activists that are in these affected communities, are in these minority communities, because it's not always effective. But the other thing I do is, because each, even within culture, people are different, is listen to my patient. And so if I can't think of an example right off, but let's just say, for instance, that I wasn't up to date, and I might not be actually up to date on the newest trans lingo, for instance. And I said something wrong, I always, ask my patients to correct me. I give them that beforehand. If I say something wrong, correct me. I don't want you feeling, uncomfortable. So, I don't want to put the work on the patient, but I want them to feel comfortable correcting me or teaching me, even though that's not their job, but, teaching me if they have to, or if I've done something that's not culturally safe or culturally competent.
How do you incorporate a trauma-informed approach when working with patients from marginalized communities?
One thing I do is ask for consent. So I work with mostly children. I do work with some adults with developmental disabilities, but I work with mostly children. And I think children is the one segment of the worldwide population where people really don't consider their consent a lot. The adults, the parents just make decisions for them. The doctors just make decisions for them. So one thing I do is I always try to involve the patient in the decision making, even, it doesn't matter their age. I guess if they're like 2 or 3 and barely talking, maybe.
Yeah.
But most of my patients are at least, 4 or 5. Even at 4 and 5, I start asking them questions. If they're on medicine, how's it affecting your body? If they have problems with it, tell me why. Giving them choices. So I do think this is going on. I think, maybe you need this type of medicine, but we can decide between this and this. What do you want to do? So I think getting consent and giving decision-making capabilities, but also just being mindful. As a psychiatrist, you're kind of trained a little bit, to see when somebody's uncomfortable. So if I see some of those signs of being triggered, just kind of backing off or asking, is this okay to continue this line of questioning, that kind of thing. Another thing I do is when I'm seeing somebody for a short visit. So if I'm seeing somebody for a consult, which means I might see them only 1 or 2 and they won't be my long-time patient, or even really the first time I see my patients, honestly, I generally don't get into a detailed trauma history. For one thing, it's their first time seeing me. Who wants to talk about all their trauma with a complete stranger, right? And if they're going to be my patient for the long term, then that's something we could get into later. They're not going to be my patient long term, then that's even more reason for them not to get into that and then bring up stuff that they have no one to help them go through afterwards. So that's another thing I do, is try to be, we have to get trauma histories as psychiatrists, but I try to say beforehand, I'm going to ask you these questions. You can just say yes or no to sexual or physical abuse. You don't need to get into details unless you feel comfortable doing so.
When I was in my first psychiatric hospital, it was in adolescence. All my consent gone because they just used an injection, restrained me and put me in holes. So that was horrible. So
yeah, I have done inpatient before, in inpatient child, and even in that, if somebody's been a danger to themselves or others, of course we have to step in and consent might be temporarily taken. But I tell people all the time, adults and kids in the hospital, I sometimes will suggest the medicine and they're like, well, I can't say no anyway. And I'm like, you actually can. You can't say no. You still have consent in the hospital unless the judge takes it from you. But I'm not a judge. So unless, a court is involved, you still have consent in the hospital. And I think that's important for people
Yeah.
to know.
Now, though, there was a petition in Parliament in the UK and they've made restraint against the law now in mental health hospitals in the UK. So can you describe any particular strategies or interventions that you use to address the unique experiences and needs of patients from marginalized communities?
I'm trying to think. Can I say that because I kind of fit into a lot of marginalized communities. So I think I just naturally do a lot of things because I fit in that intersection.
I have a care plan and I did some mind mapping and did what am I like when I'm well and then what I'm like when I'm unwell. So I got a mind map about that.
Oh, yeah, that's really good. So that's one thing I do in outpatient, but especially in inpatient. If I'm seeing somebody who is going through a crisis, I obviously have no idea what they're like when they're not in crisis, right? So another thing I try to do is talk if permission is given, talk to family and see what patient's baseline is, like how they're like when they're not in crisis, so that I know exactly not exactly, that I know what we're treated. So an example would be somebody that's super religious. Being super religious can be delusional at times, but most of the times it's not, right? Like there's lots of super religious people of different religions throughout the whole world. I come from a very religious household. So if I have somebody who's talking to me about God a lot, and it's not frankly like super obviously psychotic, like, did I get background? So is this somebody who goes to church like just on Christmas and doesn't really talk about God and now they're super religious, out of the blue? Or is this somebody who goes to, church or temple or mosque or whatever 3 times a week and this is part of their daily conversation in general? And then I kind of know, okay, well, maybe they just have depression or maybe it's depression. It's like, it kind of helps you guide, right? It first of all, it helps you know your patient, but it also does help guide diagnosis and what's normal for them and what's not.
Yeah, when I'm psychotic, my delusions are more things to do about the royal family and the government, and then I have a machine. Yeah.
Yeah.
How do you work to eliminate any biases or stereotypes that may affect the way mental health is perceived or treated in patients from marginalized communities?
So one thing is this. So stuff like this, I do podcasts. Generally, if somebody invites me on a podcast and wants to talk about mental health, I say yes if I can.
Yes.
Because I think just right, I think just getting the information out there. The other thing is I'm very open about my own mental health struggles. So I am neurodiverse, but I also have like depression, anxiety, PTSD. I think that's it. And so, I'm open about that. And, the other thing is just helping people find community. So helping people find people that they can talk to, because sometimes that's, home isn't safe or work isn't safe or wherever isn't safe. So I think although the internet gets a lot of bad reputation and it definitely has dangers for sure, but I think one of the places the internet has shined is helping people find community.
Yeah, I've got complex PTSD and it's really good actually because I've been having transcranial magnetic stimulation therapy. So my trauma
How's that going?
is really good. My trauma markers are this one. So really good. I don't react.
Nice.
And I can go back to where the trauma happened and I don't react at all.
Nice. Yeah, I haven't done a lot of work with TMS myself, but I actually have a couple of friends who have done it, like, as patients and thought it was helpful. I'm currently doing ketamine treatment for my depression, which has been helpful. I've had to be off of it for a couple months because of other stuff that's going on, and I definitely see the difference. But looking into EMDR too to help with my trauma. What my therapist that I have now does do EMDR, but we're just waiting for a good time to do it because I'm also doing ketamine therapy. So the ketamine also comes with therapy. So we're kind of waiting till we get through with that and then start EMDR. So, but yeah, and I think with complex PTSD, right? Like that's I don't know about in the UK, but in America, it's not part of the DSM. So it's not technically a separate diagnosis, although I diagnose it all the time because lots of people have complex PTSD. So a lot of times I have to put PTSD for billing purposes, but we know that PTSD from one event, which is still, something that needs to be treated and is not fun, it's hard, but it is different than kind of that chronic childhood trauma causing complex PTSD. And a lot of the treatments can be the same, but there are some things you have to be more mindful of with complex PTSD for sure.
Yeah, TMS is definitely more known in America. In the UK, talk to friends and family, and they don't know. Like, it's very new treatment in the UK.
Mm-hmm.
And EMDR is, got autism as well, so I find it hard to talk about it. So TMS, I don't have to talk, and it's
Yeah,
easier for me.
yeah. Well, that's another trauma-informed thing that I try to tell patients who, especially kids, I mean, all patients, everybody. There are certain people who do not want to talk about their trauma, and that is valid. So I try to make sure that people know that there's different types of therapy. So there's some therapy where you talk about the trauma, and there's some where you don't. I actually have been in therapy for a really long time, off and on, but consistently for at least the last 2 or 3 years. And I'm just now getting to the point where I want to talk like more in depth about my trauma as a psychiatrist myself. So but I definitely was helped by other types of therapy that didn't necessarily, like, we might have brought it up, like, oh, this happened, but it wasn't going like deep into it. I wasn't ready for that. And if I am very good on setting those boundaries, but a lot of people are are not, and not because it's, not because they're not necessarily good at boundaries, but you expect your kind of therapist to not do anything that's unhealthy for you. But people are different. Everybody's different. So I always make sure people know, like, make sure you have a good connection with your therapist. If you don't, get another one. And also make sure they know your boundaries. Like, if you want to do a type of therapy that does not involve talking about your trauma, make sure they know that and they should honor that. And if they don't honor that, definitely get another one.
um, when I'm psychotic, my autism, I don't speak at all. It turns really severe autism, and I'm completely mute.
Mhm.
So there's not a chance in me talking at all. So
Right.
how do you involve any and educate families from diverse backgrounds in the diagnosis and treatment process?
Yeah, I really just talking, giving them the understanding of what's going on. I think, in the United States, particularly, all throughout the world, but, in the United States specifically, there's a mistrust of the medical community and Black and Indigenous populations for a good reason. The medical community did lots of horrible things to Black and Indigenous people.
Mhm.
And so a lot of times, you have to acknowledge like that mistrust. Like, so one thing in the Black community I say is, until very recently, I mean, it's still in the community, but a lot of people are like, you just want to put my kids on medication. You just want to, and that's not even, let me say that, it's not just the Black community. Psychiatry in general has that reputation of, you just want to put my kids on medication. You just want to turn them into a zombie. And honestly, in the olden days, we didn't have as many choices in medications we had then. So there were maybe, different, stronger side effects. So I'm not saying that there's no reason for that. And then with our education system, until very recently, like, if you had a diagnosis of neurodiversity, they really just kind of pushed you to a classroom by yourself. Special education was a classroom by yourself where you didn't really learn anything and you didn't graduate with a real diploma. That's different now, in the educational system. But, my parents, and even I remember going to school and all of the special education people being in one classroom. So that's not that long ago. And so these parents remember that, and they're like, you just want to, label my kid and not teach them, or label my kid and just give them medicine, just throw medicine at them. So I really go through what labels me. This means that we could get help now. This is how things are different. This is how we can do things now. And psychiatry is still kind of you have to try a med, see if it works, try another one. Unfortunately, we are still there, but I'm upfront about that. Like, this is, going to take patience and time. And, I'm neurodiverse and I parent neurodiverse kids. And although I don't tell my neurodiverse kids, I don't tell their story necessarily, but I do tell people that, I parent neurodiverse kids. My kids are on an IEP. My kids see a psychiatrist, take medication. So I'm not doing anything, to you that I wouldn't do to my own kids.
Yeah, I have had problems in the school system myself. So my mum took me out of school when I was 10 years old and home educate me.
Mm-hmm. Yeah,
So
I'm actually doing that for my son now, just because he is just really soft spoken. And so he doesn't really speak up when he needs help or doesn't understand.
Yeah.
So now, right now we're doing a kind of a mixture. He's at home 3 days a week doing homeschooling, and he goes to school 2 days a week and gets like his special education and still gets time to, have some social time and all that kind of stuff. And
Yeah.
he really likes that. My daughter's still in school full time, but more because she's a little bit harder to keep on track at home. Like I would have to have the money to hire an actual teacher, which I do not
Yeah.
because I work full time, so I couldn't do it. But yeah, I think knowing your kid and knowing that homeschooling is an option is good to know.
Yeah. And for me, like I had more of a social life at homeschool as well, because it's like a community. So there's
Hmm.
meetings. I made some like lifelong home education friends. So that's yeah.
Nice. I remember oh, I'm sorry, I just want to say this one part. So when I was in training, I remember being told in training that it's important for kids to go to school and not homeschool for the social aspect. And I just kind of want to speak on that a little bit. I do not agree with that. Like you said, there are homeschool communities, so you can still get the
Yeah.
social aspect.
And it's
And the other
actually
part is if you're being traumatized in school, nothing is worth traumatizing your kids. Like being them having social opportunities isn't worth them having PTSD. So you have to do what's best for your kid.
yeah, and it's actually more sociable because you socializing with all age groups and you're not
Hmm.
just socializing with your class. So
Yeah.
it's definitely, and you're socializing with like different majorities all around. So
Right. Right.
how do you ensure that your practice is inclusive and reflective of the diverse communities you serve?
So, as a psychiatrist, I work for a company. So the company itself is very diverse, but I also don't live in a very diverse place, to be honest. So I don't know how diverse it could be. But as far as like how I practice psychiatry, I do. So if I have a kid that needs therapy that is, say, indigenous, because we do have a pretty decent indigenous population here, I might not be able to find them an indigenous therapist, but I maybe can find them a therapist who is kind of plugged into the indigenous community or a mentor who is indigenous or plugged into the indigenous community. So I try to just be mindful of finding people who we may not be able to find somebody that's in their culture, but finding somebody who at least understands it is how I try to make sure that things are diverse and culturally competent. Because I honestly live in probably I haven't looked at the stats recently, but I would say at least 95% white city, and then
State
that
do you
5%
live
is
in?
made up of
What state do you live in?
Minnesota. So Minnesota is not very diverse, but we do have where I live. There's a decent Hmong population, which is Asian. We have a decent indigenous population, and the Black population is growing. But in the health field, there's still not a lot of diversity as far as clinicians. But like I said, I work really hard on trying to hook them up with somebody who is at least trying to learn.
Yeah, absolutely. How do you make sure that the resources and services offered are culturally appropriate and accessible for patients from marginalized communities?
So kind of that same thing. The other thing is so I actually work in Wisconsin. I live in Minnesota, but I live so those states are right next to each other, and I live kind of on the border. So there are a couple of cultural, what do you want to call it? I guess cultural organizations that do some community work. So if I can't get, like a health professional that's culturally competent, I might refer them. So there's an organization called Black that stands for Black Leaders Achieving Collective Knowledge that does a lot of community work with kids in the Black community. And I don't know the name of this one, but I always like if I need to find it, I have friends that are in all these things. So I just text them like, but if I need to find, if I have somebody that's in the Hmong population and I want to get them hooked into like their cultural groups or that like I said, I just kind of text my friends and I'm like, what are the next steps I need to take in and get the kids hooked up with somebody. So yeah, it's not a lot of formal help with diversity, but mentors, people to just kind of take them under their reins. We definitely could get them hooked into that.
Yeah, that's good. How do you stay informed and educated on the latest research and best practice for working with patients from marginalized communities?
Conferences. So I go to at least one or two conferences a year for psychiatry, and then normally they have, different classes you could go to. So I just kind of pick my classes based on, things I need to learn about. The other is I do get magazines like the Child Psychiatry Organization for the US. I'm part of that organization, so I get magazines every month. So reading those articles. So really through that kind of thing from the medical perspective, from the personal perspective or the firsthand perspective, again, listening to people's stories. So whether that's through, sometimes some of these conferences have people that they, bring in. So whether it's through that or whether it's through following people on social media. Honestly, that's where I get a lot of the firsthand stories
Yeah.
is following people on social media. So those are the kind of the two ways that I try to stay up to date on what's going on.
How do you address and actively work to dismantle systemic racism and oppression within mental health system?
Yeah, so I run a group, a nonprofit group, but it's also a Facebook group called Physician Women SOAR. So it's for physician women or non-binary people. And in that group, we do a lot of educating just on systemic racism and personal bias, but even more than personal bias, systemic racism in history. I also offer trainings to companies on anti-racism. And the other thing that I do is, I guess, doesn't necessarily fight systemic racism, but I am part of an organization that helps Black residents who are maybe being discriminated against and kind of pushed out of residency. Of course, we need more Black doctors in medicine. So we kind of try to step in and help those residents not get pushed out of the medical field. But yeah, it's a lot because I mean medicine, particularly in the United States, I can't speak for other countries, but medicine in the United States is literally built off racism. It's built off testing Black slaves, without consent. So it's kind of hard. I mean, we still do it. I'm still gonna fight every single day. But I think it's really hard for people to see just how much it's based on racism and how much really needs to change. I mean,
Yeah,
there's still doctors who think that Black
it has.
people don't experience the same amount of pain as other people. And
Yeah,
that's today in 2023.
I mean, some will argue that the effects of slavery is still happening today and it hasn't actually been abolished.
Correct. And, a lot of people don't want to think that, right? They want to think we're much further along than we are. But slavery is a echo of economics in the United States, medicine, education. I mean, it's really just all throughout the United States because that's what it was founded on. And of course, there were slaves throughout the world. And so a lot of people, say there's slavery all over the world, and that is true. And there's a lot of racism all over the world, not just the United States. But the brand of slavery was a little bit different in the United States than it was elsewhere. And I think that's why it's just a fabric that we need to dismantle from the ground up.
Absolutely. I read an article about systemic racism, and it was Jeremy Clarkson, and he said some awful things about Meghan Markle, and that's, I mean, in the UK, I
Yeah.
don't like him at all. Definitely a problem in the UK as well. How do you involve patient community and leaders in decision making and evaluation of your practice and services?
So again, I work for a company and they send out evaluations. I honestly am not completely sure how that works, but I do know that I get evaluations.
Yeah.
Well, I guess I do know how it works because I'm also a patient through that same company. So normally after a visit, we just get either a text message or to our computer, chart that we can log into. We get the option to give an evaluation and leave feedback.
Right. How do you make sure that your diagnosis and treatment does not penetrate racial and social injustices?
I always try to reevaluate or keep evaluating my diagnosis. And if I feel like I've reached a wall, or if I feel like I'm not sure, I am quick to call in fresh eyes. Like I am not offended by getting a second diagnosis or yeah, second opinion. I'm sorry, not second diagnosis. I'm not offended by getting a second opinion. If I have questions myself, I mean, I will ask people or either, send the patient for a second opinion. If the parents has questions, I always say you could get a second opinion, not in a, you could get a second opinion, but really, people, that I'm human, so there might be something that I'm missing or not looking at. The other thing is there is built into our boards, there's peer review. So you're always kind of being reviewed by peers a little bit. It's not a whole lot of peer review, I won't say that. But the other thing that me personally, is if I truly have a question about something, or if I'm like, maybe I'm missing something, maybe I'm not looking at it as something, bring it to colleagues. Like I use my friends, as my physician friends and colleagues, as resources to make sure that I'm looking at things correctly. Especially if it's a cultural thing that maybe I don't, understand, and I know somebody that's in that culture. Again, knowing that every person in every culture is not the same, but they'll know more than I do, right? So I have no problem asking for help.
How do you address the impact of structural racism and discrimination on mental health outcomes?
Yeah, honestly, I think acknowledgement. So, a lot of times we are treating systemic effects, I guess you could say, in psychiatry. So, like, if you're somebody who is struggling because of poverty, or you're struggling, and poverty a lot of times is rooted in systemic racism or ableism, all of those things. Or if you're somebody who's struggling with, I'm trying to think of systemic things, that's why it's taking me a while, but with, I don't know, like during COVID, maybe kids that were struggling with not being able to go to school, although some, I acknowledge that I can't necessarily fix your poverty, and so I'm treating symptoms, when really the real issue is the poverty. That said, I do also try to give resources, but it's hard to access those resources, even if you qualify. So here in the United States, we don't have a universal basic income. We don't have universal health insurance. So to qualify for federally funded health insurance, you have to be a certain age, like elderly, or you have to be disabled, or a kid. I think most kids in most states can qualify. But if you aren't meeting these criterias, then you're kind of in that space where you're not even able to access the few services or the few resources we have. And so I just have to acknowledge and hold space that you're depressed because you're going through this, and I can't fix it for you, but I still want you to enjoy life as much as possible.
Yeah. Can you describe your understanding of the link between race and ADHD in women?
Yeah, I think, well, let's talk about women and ADHD first. So women in general. I think it's underdiagnosed in minorities, all ethnic minorities, and in women's. Well, not I think. The research shows it's underdiagnosed. And the reason that is again, a lot of the research for ADHD, as well as a lot of things in medicine, a lot of research in medicine is done on white males. So the research for ADHD was done on white boys and how they presented. And so the hyperactivity, like women can be hyperactive, girls can be hyperactive, and they can be physically hyperactive. That's true. But generally, because of the way girls are socialized, they're not going to be running all up and down the halls. They're not going to be bouncing off the walls. If they're hyperactive, their hyperactivity might present with always interrupting their friends, or always talking out of turn, or raising their hand but blurting out the answer before, the teacher calls on them. So it's going to look different generally between women and boys. So girls get missed, especially girls that are still making good grades, right? Because you can make good grades and have ADHD. Obviously, we know that. But if you're making good grades and you're not like causing problems in the classroom, the teachers aren't going to be like, "Oh, she makes careless mistakes, but she still made an A. I should send her for ADHD." They're just going to be like, she made an A. Let's keep it going. So a lot of girls and women get misdiagnosed, or not misdiagnosed, get missed, do not get diagnosed. So, and then in say Black communities, because of racial stereotypes, so say you have a Black boy that's jumping and running around, and a white boy that's jumping and running around, the white male might get sent for testing for ADHD, where the Black one is just going to get in trouble for being quote unquote bad, right? Because they think that Black people are bad anyway. So they're not going to look for, is it something that's going on? They're just probably going to jump to, he's just bad, or his parents just need to discipline him, or he probably don't have a dad at home. All the negative stereotypes, which are, probably not even true about this kid, right? Another thing we talk about a lot is in Asian communities, because there's so much pressure to make these good grades, even if that means doing nothing else in your life. They may get missed, or parents might not want to take them because of the cultural norms, and that's just not a cultural norm. Or immigrant communities, kind of same thing. You just don't do psychiatry, right? Like you just figure it out. You don't do psychiatry. So they're not getting taken and they're also not getting picked up by the teachers. Or if the teacher does pick it up and say, I think you should maybe, go see a psychiatrist, they're not going to take them because they just don't believe in that. So I think the first issue is that it looks different between males and females, again, in general. And then the second issue is bias. If you see somebody doing something that you're already biased against, you see a kid making bad grades that is, Hispanic and doesn't speak English, you might just assume that they don't have the intelligence to make good grades versus they have a learning disability or ADHD or autism, right? Obviously you should not assume that, but we're not going to pretend like that doesn't happen. It definitely happens. So there's that part, the bias, and then there's the actual community, and most of the Black, immigrant, Asian, a lot of these communities don't trust psychiatry in general, which again, not without reason. So that's not on them, that's on us to fix. But that's another barrier to diagnosis, is sometimes your own community.
Yeah, interesting. How do you think that the medical community's understanding of ADHD in women has evolved over time, particularly in regards to women of different ethnic backgrounds?
I think that it is better. I will tell you, as a psychiatrist that is neurodiverse and in these psychiatry groups, I think neurodiversity is still very poorly understood. And I think part of the reason is, so in psychiatry, when you become a psychiatrist, you have to do an adult residency. Like everybody that's a psychiatrist can treat adults. And then any other specialties is after that. So to treat children, I had to do an additional 2 years. To do forensics, I think it's an additional year. To specialize in, what's the word I'm looking for, in elderly, it's an extra year. And I said that to say adult psychiatry obviously doesn't cover developmental things. So part of it is that a lot of the mental health field doesn't get education on developmental diagnosis unless you specifically treat children. Weird to me because children grow up to be adults. I feel like it's backwards. Like I feel like everybody should do child psychiatry and then specialize in all these other things because none of that stuff goes away just because you become an adult. I think that's a big part of it. So things are getting better. I've done talks for adult psychiatrists where they're really interested in learning how to diagnose not autism, well, autism too, but learning how to diagnose ADHD, autism, all these things in adults and how to treat it appropriately. Just things that weren't covered in adult psychiatry residencies. Even when I was in residency, which is just a few years ago. Like I said, those things are starting to change, but they're kind of just starting to change. So it's going to take a while for that to catch up.
Yeah, absolutely. It's going to take a while. How do you address the interconnectedness of race and gender when working with women of different ethnic backgrounds who have ADHD?
I think again, acknowledging I don't treat a lot of adults, to be honest. And most of the adults I treat more vulnerable adults. So I treat adults that like live in group homes or foster homes. So I don't treat a lot of adults that are not living in like group homes or foster homes. That said, as far as in the coaching world, because I do have like my own coaching business or I do speaking engagement. So in the speaking engagement coaching world is where I kind of treat more adults with different, adult women with different ethnicities. And that is the thing the thing I want to do first is, just talk to them, learn about them. But one of the things, and I do this, this is my mantra, find your people, right? So the other thing I do is hook them up with, or try to get them hooked in with with people that are like them. So if they're Black with ADHD, Black women with ADHD, Indigenous women with ADHD. I did a podcast with a Muslim woman with ADHD where we talked about high achieving women of color who are diagnosed late in life, which is not uncommon, right? So getting them hooked up with people who are going through the same thing. So for that support system. And then acknowledging the other thing you have to do is acknowledge the cultural difference when you're coming up with a treatment plan, right? So if you are a first generation immigrant family and you're like, I kind of want to take medicine, but my family, is not going to be on board with that. So then we have to discuss the risk and benefits. Like, do you take it? Do you not tell your family? Do we try to get your family on board? Like you have to figure out how to address cultural sensitive things, especially when it's different. Like in America, America is more, what's the word I'm looking for? Family, not family. Oh, I can't think of the word when it's just like the parents and kids. What is that called?
I can't think.
Like not extended family. Oh my God, I can't think of the word. But America is kind of more centered on just like the two parents or whoever the parents are and the kids as a family versus I got to consider what my grandma thinks or I got to consider what this person thinks. Whereas other cultures, pretty much just about all other cultures outside of European cultures. Well, actually, I would say outside of America and the UK, because even other more ethnic European cultures are more community centered, right? So if you're working with a patient or a client in the coaching business from a community centered culture, you can't just go in there with like an American attitude and be like, it doesn't matter what your mom thinks. Like that's just not culturally sensitive. So you have to acknowledge and work with those cultural differences and sensitivities.
You say you work with children, so when children come to you, are they like undiagnosed with autism, ADHD? Because like for me, I only got diagnosed
Sometimes,
with lockdown, and in women, autism and ADHD get missed till adulthood.
yeah, so sometimes they're undiagnosed. Sometimes, they're coming to me and they've been diagnosed before and they just are maybe moved in or changing physicians for whatever reason. I do, I have kids, especially teenagers sometimes that come in and I'm like, oh, you're definitely autistic or you're definitely ADHD. And so they made it all the way to like 16 or 17 and never been diagnosed, right? But yeah, I do diagnose a lot. I have some people that come in with diagnosis. Generally, I don't send for testing because the diagnosis of autism, ADHD are all clinical diagnosis. The only thing that you actually need psychological testing for is for diagnosing learning differences, so learning disabilities and intellectual disability. That said, sometimes psychological testing is helpful if the diagnosis isn't clear, because sometimes ADHD, autism, anxiety, severe anxiety, all of that could kind of look alike, or sometimes you could have all three.
Yeah,
So all of that gets
my first
good.
diagnosis was verbal dyspraxica, and my speech
Mhm.
therapist didn't want to diagnose me with autism because speech and language difficulties can look like autism. So
Mhm.
probably why I wasn't diagnosed till later.
Yeah, exactly. So if I'm confused in any way, or if I want like more guidance for like what accommodations might help them in school, then I do send them for psychological testing. But otherwise, yeah, I just diagnose myself when I see them.
What steps do you think need to be taken to address the issue of racism and bias in the diagnosis and treatment of ADHD in women of different ethnic backgrounds?
A revamp in medical school education.
Yeah, absolutely.
So yeah, I think that's the answer.
Yeah, absolutely. How do you ensure that your practice is inclusive and culturally sensitive when working with women of different ethnic backgrounds who have ADHD or autism?
So yeah, kind of the same with my teenage. I guess I'll talk about my teenagers. Again, listening, especially with the autistic population. I'm autistic, but I discovered that very late in life, like maybe 2 years ago. So even well after I was diagnosed with ADHD. But there's other things that go with it. So the likelihood of being like queer or having, depression, anxiety, all that is increased in autistic, communities. So my teens who maybe are autistic and feeling really alone, listening to what's really going on, what we're really treating. Because you don't treat autism just you don't treat autism, right? Like you're not saying you're autistic, this is the treatment for autism. You're figuring out like what they need help with or what they need support with, right? So are you more anxious because of the non-conforming world that we live in, right? That kind of doesn't allow you to be yourself. And I can't change the world, but I can help you be less anxious so you can enjoy it more. So really just listening, working with people. If it's like again, like I said, if it's something I don't know, bringing in help, asking for a second opinion, as talking to a friend. What show used to come on? Who Wants to Be a Millionaire, where you could phone a friend. I don't mind phoning a friend.
Yeah,
Gotta bring it in help.
a lot of eating disorders as well. People with anorexia
Yes,
have higher autism
yes, yes.
rates. Do you like in like hospitals, they eat in group settings and
Yeah, I don't do a lot of eating disorder treatment. Of course, I have patients with eating disorder. So I try to get them hooked in with psychologists or therapists who
Yeah.
specialize in eating disorder. There are very few medications. There's a couple. There's very few medications that kind of target eating disorders. So really, my role, since I don't treat it myself, like I'm not a psychiatrist that specializes in eating disorders, it's finding them the correct support. That is definitely not my wheelhouse. So I won't try to
Yeah.
pretend it is. So
Yeah.
yeah, I just find them good support.
Yeah. How do you involve and educate families from diverse backgrounds and in the diagnosis and treatment process for ADHD or autism?
A spill I give in general that in my opinion I think ADHD and autism were both genetically selective positive traits. So if we're thinking about, if we go back to quote unquote caveman days, ADHD, let's say we're talking about ADHD. People with ADHD, we call it attention deficit hyperactivity disorder, but with more knowledge, we know that it's not really that you're not paying attention, is that you have trouble focusing your attention on one thing. So it's you paying attention to lots of things at once, right? So that's actually pretty helpful if you're a hunter gatherer, right? Like if
A
you're out
lot,
hunting and you kind of
a lot of all
go ahead.
ADHD symptoms is I was diagnosed with auditory processing disorder, and
Hmm.
is often it's often the sounds in the environment and how you process the sound. And the two, audio processing disorder and ADHD, they very overlap.
Yeah, and so using that as an example, so some people with audio processing disorder can hear very low sounds louder than other people, right? My daughter is one of them.
Yeah,
She'll be like, "There's a
yeah,
pain
that's
passing by,"
me.
and I'm like, "What are you talking about?" And then there's a pain.
Yeah, that's me.
And so think if you're a hunter gatherer, like in that part of the human history, if you can hear, the lion going through the savannah or whatever further away than other people could, helps humans stay alive,
Yeah,
So I lot of these traits, even though in medicine we work on a deficit model, we work on like what's not what you need support with, but a lot of these traits helped humans stay alive. So I think when you explain it like that and help people understand like these are traits that honestly have helped
yeah,
humanity. A
absolutely.
lot of inventors, if not the majority of inventors, are either ADHD or autistic. So these traits have literally kept humans alive and evolved and pushed the evolution of human society.
Yeah, absolutely. How do you address any language barriers or cultural
Oh,
is
hmm yeah, we use interpreters. So since I do work for a pretty big company, we have interpreter services that are pretty easy to schedule. They could be in person or over the phone. I generally try to do in person at least the first few times that I'm working with somebody. If it becomes like a patient that I've known for a while, normally over the phone is suffices. Generally, the language, that we get the most is Spanish, which I know a little Spanish, not enough to not have a translator, but at
yeah,
least enough to make sure the translator is translating correctly. But other languages, so we do have like Hmong interpreters and things like that. So one thing I try to do, even when using an interpreter, one thing I was taught, so I was taught this in resident in fellowship, and I think it's a really good lesson, is you still talk to the patient. So a lot of people when they're using an interpreter, they look at the interpreter, and then the interpreter looks at the patient. I still talk directly to the patient, like the interpreter can hear me just fine. So I still look at the patient, talk to the patient, and let the interpreter do their business.
do you like draw and say to the
I
patient?
have.
Yeah,
I have. Yeah, I I have a whiteboard in my room, so sometimes I do draw out concepts for even English speaking patients. So
yeah,
so it's easier to
yeah.
understand, or for
I
my
do.
kids, or So yeah,
When I'm psychotic and in hospital, I find like having pictures definitely. I just point to them and definitely helps so much.
yeah, definitely. If somebody's overwhelmed, my my daughter's similar in the fact that when she's overwhelmed, like you have to use less language with her. Like that's not the time to launch into a speech.
Yeah,
But so I even do sometimes I have a stop sign or it looks like a stop sign, but it's red on one side and it's green on the other side. So sometimes when she's overwhelmed, I just hold up the stop sign to kind of help her like calm down and just seeing that like red or green,
yeah,
like calm down or okay, this is good. Or shortening down to one or two word phrases. And I do that at work too. Like if
Yeah.
kids are overwhelmed, you back off. I mean, as adults, when you're overwhelmed, you don't want nobody in your ear lecturing about
No,
anything.
I just want a dark room and weighted black.
Right.
Yeah. How do you evolve and collaborate with community leaders and organizations to address the issues of racism and bias in the diagnosis and treatment of ADHD?
So our local community, the community I live in is different. Is like a different city than the community I work in. I think our local community where I work does a good job of reaching out to community leaders to get involved in different programs or host different programs. The community where I live, not so much. And I'm gonna be honest, I don't do a lot in the community I live in because I don't have the spoon. I just don't. And because it would literally be building from the ground up pretty much. So when I'm asked to speak, so I do participate in our school district's special education committee. So I'm a part of that. So I definitely work to make that more diverse. But outside of that, I guess I don't do a lot in the community where I live. I do more in the community where I work.
Yeah. What state do you work in?
So the state. I work in Wisconsin, but I live in Minnesota.
How do you ensure that your practice is culturally responsive when working with women of different ethnic backgrounds who have ADHD?
The organization I work as a whole does hold or does have like different continuing education you could do on diversity and inclusion. Me specifically with my patients, I do a lot of work in the diversity field already. So I guess I don't do any extra because normally when I'm speaking, there's other speakers there of different ethnicities. So I hear a lot of culturally competent stuff just by the outside work I do through my side business. But our company as a whole does have continuing training for diversity and inclusion.
How do you ensure that your practice is inclusive and reflective of diverse communities, particularly when it comes to ADHD and women?
I think one thing that has changed at the organization that I work in, so again, I'm very open about my ADHD at work and outside of work. So I have seen more clinicians be a little bit more open about theirs. Some of them have just kind of sent me stuff in private, like, oh my gosh, I have this too. I'm so glad you're speaking on it. But I have seen more clinicians be open, which I think always helps our population. The other thing is just again with me personally and the way I practice psychiatry is, explaining to parents. So I do get a lot of parents who maybe have a son that's diagnosed with ADHD or autism and has a daughter that is having difficulties, but the thought of ADHD or autism never really crossed the parents' mind because they're not presenting like their brother or like the son. So having those conversations with parents and families about how things present differently in women and kind of, getting them to the same understanding where actually they do have the same diagnosis, even though they present differently. I think that's really helpful for families.
Absolutely. How do you work with other professionals such as primary care physicians or mental health providers to ensure that the needs of women of different ethnic backgrounds with ADHD are being met in an all-inclusive approach?
So one thing my organization does is we do what we call one-time consult. So it's hard to get into psychiatry. We have a really long waiting list. So we will do like collaborating with primary care on patients. So maybe the patient sees me one or two times and I kind of get a diagnosis, get medications going, and then send them back to their primary care physician with just kind of a write-up of like, this is what I think is happening. These are the next steps to take. So working with other clinicians in that way with other mental health professionals. So, some of my kiddos have a full team, right? Like they have me, they have the therapist, they have community supports. So one thing I try to do is attend, a lot of the community supports have to meet every so often. So if they're having supports that meets like every month, I try to attend that meeting. I try to make my appointment with the kid the same time as that meeting, once every 3 or 4 months or something like that, so that everybody's able to get on the same page and make sure we're all on the same page with providing care for that patient.
Yeah, that's all the questions done. I finish off with some like silly questions to
Okay.
have. So the first question is like, what do you prefer, beach or mountains?
Oh, beach. I love beach and water. I love sand and water.
Yeah. I love the beach. I love this.
Yeah. Yeah, I do like staying in cabins on the mountain. That's true. But I guess if I had to choose, and I grew up close to a beach, so that might be part of it. It reminds me of home. But yeah, if I have to choose between the two, I'm choosing a beach.
Are you an early morning lark or night owl?
Night owl.
Yeah, I'm the same. Hate mornings. Yeah.
Yes.
And crunchy or smooth peanut butter?
Smooth. The crunchy texture does not, I don't like it. So
I,
texture-wise, I don't like anything that's like mixed. So like those candies, like the gusher candies, and so you bite into it, and then there's this like juice scraping out. So anything with like that mixed texture, I don't like it. And crunchy peanut butter has like smooth in some parts and crunchy in some.
Thank you for being on my podcast, Loucresie.
Thank you for inviting me.
It's been a pleasure. Thank
All
you.
right, you have a good night.
Thank you. Bye.
Bye.
Yet another wonderful interview. Much obliged for you to stay and listen to Happy Go Lucky at Heart podcast. If you enjoyed the show, please keep on boasting about it to your friends and family. And if you have any spare time, please help an independent podcaster get known. So please leave a 5-star review on whichever podcast platform you listen on, and click the link in the show notes for many more ways to connect with me. Bye! Mwah!